Okay, so I thought what would be interesting and hopefully helpful was to talk about some of the problems I see with management of dental trauma. I'm not doing this to criticise people, and I do need to point out some things at times that maybe haven't been managed as well as they could be. For whatever reason, I don't know at the time. Like, at the end of the day, we're dealing with a patient, and often these are young patients, kids. That's the most common time for trauma is in children, and it can have lifetime consequences if the right things are not done. So there are just a few things I want to talk about. So firstly, I want to talk about when should you do root canal treatment. Secondly, emergency treatment. And thirdly, root fractures. These are the three most common things I see that are problematic in trauma management. So let's firstly talk about when to do root canal treatment. I'll start with this case here. The young girl, she was 10 years old. It was a Saturday night. The family was visiting another family and the kids were all walking around. And she hit her head on the back of her friend's head. It wasn't terribly severe, but the parents were aware that it happened. The teeth were a little bit tender. They didn't rush off to see a dentist or the hospital or anything. They waited till the Monday morning, went on to their family dentist. And that dentist wanted to do root canal treatment on the 2-1 and 2-2 there and then. The subsequent diagnosis that I made along with the paediatric dentist before I saw the patient was that these three teeth had been subluxated. So two of them, the dentist wanted to do root canal treatment straight away, based on the fact that they didn't respond to cold spray. The mother didn't like that. The mother was very conservative, which is good. So she said, no, I don't want you to do that. I'm going to take my daughter to see a paediatric dentist because the paediatric dentist sees my older daughter. So the dentist says, okay, I'll give you some amoxicillin. Why? Why? There's a few things here. Why give an antibiotic for subluxation? Cold spray pulp test, is that really adequate? Well, the paediatric dentist saw the patient the next day and took a thorough history, really found out what actually happened, did a thorough clinical examination. That included some radiographs, and this is just one of the radiographs. There were others, in a typical trauma series of radiographs, you should have at least 3 periodicals of it's trauma to outrange heritage, should be at least 3 periodicals in the occlusal, plus look at the opposing arch as well, maybe at least 1 or 2 PAs, maybe an occlusal to see if there's other damage that's not that obvious. So if you only take 1 PA, you can miss a lot. But I'm only showing you one of the radiographs here because it just shows those teeth there. She also did pulse sensitivity tests with CO2 and an electric pulse tester. If you're going to do a pulse test, that's what you're going to do. Cold sprays, yeah, sort of okay, but they're not that ideal, they're not that reliable, really. So this was 3 days after the trauma. And remember, with cold spray, neither of those teeth responded. The CO2, the lateral did. They didn't respond to electric pulse tests, and the central didn't respond to either test. That's okay. Just a couple of days after trauma. So the paediatric dentist then referred the patient to see me. And all I've been doing is just monitoring this patient. So I saw her a few days after this. I didn't take another radiograph at that time. We repeat the tests, and then the first time, I'm not showing you every time I've seen her, but 2 months, okay, no responses there. 5 months, lateral was responding now. 8 months, central starting to respond to cold, and 11 months, both back to normal. The dentist wanted to do a root canal treatment on 2 teeth on a 10-year-old girl. And that just shows he or she, I don't know the number, doesn't understand what they're dealing with. Pulse can recover. Just like you fall over and you cut yourself, your skin can recover. Fall over and break an arm, your bone can recover. Teeth can recover too. got to give it a chance. It can be slow to recover. We're not talking about a tiny little late foramen, even if it's a younger tooth, it's still an area of an apical foramen is not that big. And you consider trying to get blood vessels to grow back in. You've got to give it time. It can recover. And the way to manage these cases is through regular follow-up, which includes radiograph mass and pulse tests. And yes, I do advocate very strongly that when you first see a patient following trauma, you should do pulse sensitivity testing. And it should be both a cold test, ideally CO2, and an electric test. But don't read too much into that. Okay? Often I hear people say in that time, I'm so busy trying to get the teeth back in place and putting a spin on and all this and that, writing a prescription for antibiotics. You can pulse test in that time. There's no excuse not to do it. Okay? You should do it, but it's how you interpret it. And it's quite common for a traumatized tooth to not respond immediately after having trauma. The tissues are not normal, they're pretty traumatized. Especially if there's been some displacement of the tooth. Or in a subluxation, can be some crushing of the neurovascular bundle of the apex. So that nerve tissue inside the pulp probably won't respond normally. It's been damaged. But that's what we want to know. So one of the reasons for doing pulp sensibility tests at that initial emergency situation is to find out whether there has been an injury. Sometimes there might not be any other clinical sign or radiographic sign of the tooth being injured, but it doesn't respond to a pulp test. So that's a red flag, saying, I'm a tooth that needs to be monitored. It's not a red flag saying, I need root canal treatment. So it's important we do it, because apart from telling us that tooth has been injured, it's giving us some baseline data for future comparison. Because we should be following this teeth up to see whether they recover or not. And another aspect of it is that it's one of the best predictors of subsequent pulp necrosis. So if a tooth does not respond at that immediate trauma period, there's a higher chance that pulp necrosis will occur. Doesn't mean it will occur, there's a higher chance. Whereas if it does respond immediately after trauma, then there's a pretty good chance that it won't get pulp necrosis. And if you look at the dental trauma guide, I'm not sure if you're aware of this website. It used to be freely available. You now have to pay for it, but it's a fairly low subscription rate. It's a really good website where you can get information very, very quickly. So if you're not sure what to do and you subscribe to this website, you can jump on there and it has permanent teeth and deciduous teeth and the different injuries here. I've just picked one here for concussion. And what it says here is usually a positive result. This test is important for assessing future risk of healing complications. A lack of response indicates an increased risk of later pulp necrosis. It's not saying a lack of response tells you you have pulp necrosis and you need to do root canal treatment. No. It's saying there's an increased risk in the future. And going further into that, you can get these graphs here. So this is the concussion with the crown fracture. So pulp necrosis afterwards. So if the tooth responds to a pulp test at that initial examination, very, very few of them over 10 years will develop pulp necrosis. But if they don't respond at that initial appointment, it's about half of them will get pulp necrosis. So it's a great predictor. So when you have to talk to the parent or the patient about, what could happen in the future with this tooth, if the tooth didn't respond to a pulp test, you're saying, well, the chances of this tooth getting necrosis, using words to understand, is a lot higher than the adjacent tooth that did respond. When you come to write a report for an insurance company or something like that, you've got some data that you can base your predictions on. So it's really important to do the pulp test, but don't misinterpret them. Don't jump in and try and do root canal treatment because the tooth doesn't respond to a pulp test. You need more than that. So when should you do root canal treatment? Well, there are times when pulp necrosis is very, very predictable after traumatic injuries. And with that would be infection of the root canal system. I'm going to come back to that in a minute. Another time we might do root canal treatment when you have a complicated crown fracture. So using the advanced classification, complicated means there's a pulp exposure. So it doesn't mean every tooth with pulp exposure needs root canal treatment, because many of them can just have partial pulp opening. It's a tiny exposure, you might be able to do a direct pulp cap. It will depend on the extent of the fracture of the tooth, and on the age of the patient, restorative needs, and so on. But in some complicated crown fractures, we'll need to do root canal treatment. Likewise, with complicated crown root fractures, root canal treatment is usually necessary there because you need to do it to be able to restore the tooth. Okay, so the pulp's exposed, you've got crown and root involved, so it's a fairly extensive fracture. You're not going to be able to do a simple consult in these sorts of cases. You're probably going to have to do root canal treatment, maybe posting the crown, maybe root canal treatment with orthodontic extrusion and some periodontal surgery, and then a posting the crown in these complex cases. The other time is when you have a coronal third supraaggressive root fracture. I'll come back to that in the last part when we talk about root fractures. But it's only this very specific situation for root fractures. Unfortunately, many dentists seem to think the root fracture means root canal treatment. It does not. It's only in these cases here, which I'll come to. In all other cases, wait and see. Review the patient with your pulp tests and your radiographs and see what happens to that pulp over time. The worst thing that can happen is that they get pulp necrosis and an infected root canal system. You do your root canal treatment there. Maybe it's a little bit worse if they also get external inflammatory resorption. But we can treat that. But there are times when we can avoid that from happening, which I'll come to in a minute. So, in the majority of the time, unless there is really obvious pulp involvement, you do not do root canal treatment. You do your emergency stuff, you reposition the teeth, you stabilise them with a splint, you suture the lacerations, soft tissues and things, and get the patient back and monitor over time. Particularly if you have an immature tooth. So an incomplete developed tooth root, the open apical foramen has a much greater chance of pulp recovery because it's wider. And the critical thing for width of the apical foramen for revascularization is 0.7 of a millimetre. It's pretty hard to measure that radiographically. So if you think maybe a millimetre, or even half a millimetre, if the apical foramen is open half a millimetre or more, give the tooth a chance to recover. Don't get that pulp out too early. So I'll come back to this point here. So there are cases when pulp necrosis is predictable, and then the root canal system can become infected. So in those cases, we will proactively do root canal treatment as soon as possible. Why do we do that? Simple. To prevent external inflammatory resorption. Remember, what that needs is an infected root canal system and damage to the external root surface. The other reason is to prevent apical peritonitis from occurring. So if you know pulp necrosis is likely to occur because of the type of injury, then deal with it rather than waiting. So how do we decide that? Well, how likely is pulp necrosis? It depends on the actual injury that occurs and whether that injury has any effect on the apical blood supply. It's all about blood supply. Okay? Forget nerve supply, it doesn't matter. It's blood supply that's important. So injuries like luxation, for instance, here a lateral luxation, as that tooth is knocked and the crown goes palatally and the root apex moves across that little lip of mine because that labial wall breaks, there's damage to the apical blood supply. It's cut off. Okay? So that tooth is lost its blood supply. If it's a fully developed tooth, it's not going to recover, or very unlikely to recover. If it was an immature tooth, it might. Intrusions, as that root is driven up into bone, it crushes the neurovascular supply at the apex. So there's a lot of damage that occurs there. Crushing is one of the worst injuries. You're better off fracturing than crushing. So here you're crushing the bone, you're crushing the ligament, you're crushing the neurovascular blood supply. So intrusions of fully developed teeth, basically forget it, the pulp's not going to recover. So it depends on the type of injury and whether it affects the blood supply adequately, and then the ability of that pulp to recover, which is largely based on the size of the apical foramen, which is based on the stage of root development. It also depends on whether there are any pathways for bacteria to get into the tooth. In other words, is there a fracture? That's obvious. A fracture, you expose dentine. Dentine is just an extension of pulp. Dentine has lots of dentine tubules, tens of thousands per square millimetre, so you have tens of thousands of pulp exposures per square millimetre. Bacteria get in. So if you've had damage to the apical blood supply and effectively blood supply has been cut off, that tooth no longer has any defence mechanisms in the pulp. And bacteria getting in the other end, you're going to get an infected root canal system that's not going to revascularise. But even things like infractions can be the same. Infraction cracks the pathways for bacteria to get into the tooth. That doesn't mean every infraction will be a problem, but potentially it is. It's something you have to assess for each individual case. So it depends on, is there a pathway for bacteria to get in? And then if bacteria can get in, can the pulp resist that bacterial invasion? And as I said, if the apical blood supply has been cut off, then the answer is no, it can't. But if there hasn't been any damage to the apical blood supply, then there can be a good chance of recovery. So you have to think of all these factors in any individual injury. Look at all the literature. Particularly when you look, most teeth that have luxation injuries have a pretty severe blow, so it's quite likely that there's a crown fracture of these teeth. It's quite common. So if we look firstly at the column over here, now this is for immature teeth, so an apex, and with a crown fracture. So if there's no displacement at all, then there's a pretty good chance the pulp will survive with a crown fracture. Concussion plus a crown fracture, about the same. The injury starts to get a bit more severe with subluxation. There'll be some cases that will necrose. Extrusion, more severe, the tooth coming out of its socket, blood vessels, depending on how far it's extruded, will either be stretched, they're stretched, that blood vessel, the lumen inside gets smaller, so the blood flow is reduced, or it's cut off completely if it's extruded enough. So more cases will necrose. And the same with lateral luxation, where the root apex goes across the bone. And with intrusion, basically no immature tooth that has a crown fracture and intrusion, pulp will not recover. When you have a closed apex, so a fully developed tooth, again, intrusion, none of them are going to recover. With lateral luxation and extrusion and crown fracture, the survival is pretty high. So those ones there, and the green ones are highlighted, along with avulsed teeth, same situation, closed apex, or avulsion of an immature tooth with a crown fracture. They're all injuries where pulp necrosis is very, very likely to occur. In some cases, it will occur. So this one, these two here, it will occur. And these two, it's highly likely to occur. So those injuries, the ones where you say pulp necrosis is quite predictable, infection is quite likely because of crown fracture in some of them, or there may be infractions. There's also been damage to the external root surface in those injuries, so the possibility of getting external inflammatory resorption is very high. So let's deal with it. Let's get the pulp out and get our anti-inflammatory antibiotic dressing in there right from the very start. So these injuries are ones where we take a preventive approach to external inflammatory resorption. Remove the pulp, as we talked about earlier tonight, get your corticosteroid antibiotic in there. But they're very specific injuries. Nothing like that case when we talk about a 10-year-old girl with subluxation without any crown fractures. And that process that I talked about earlier on is what we would follow in those cases that I just outlined. So to summarise that first bit, when you do root canal treatment, well, those cases where pulp necrosis is predictable, so we just talked about that, complicated crown fractures, particularly if it's related to restorative needs, the same with a complicated crown root fracture and supracrestal root fracture. All others, wait and see. Give them a chance to recover. You'd be surprised how often they recover, but also be patient. You're not going to recover in a week. You're not going to recover in a month. It might be 3 months, 6 months, 9 months, 12 months. So the second thing is inadequate emergency treatment. Now, this is really disappointing when we see it. We actually had 2 cases just recently that come to us at the school. And this is one of them. This poor patient had trauma 3 months ago. And look at what we've got here. The dentist did nothing, except write a referral and a prescription for amoxicillin. Good old amoxicillin fixes everything. I don't know how it's meant to fix these fractures. And he's lost the ground of that tooth there. So, he's been walking around for 3 months with that. And obviously, any time he goes near this area here, it's painful. That, to me, is just absolutely shocking. It shouldn't happen. Any dentist should be competent enough to at least deal with the immediate side of it. Absolutely you can't do it. Get on the phone and call someone for help. And most people that deal with trauma are endodontists, or this was an adult, so you wouldn't go to a pediatric dentist, but endodontists are generally, oh, look at that. In this case, it came to the school. If they'd run us, we would have had that patient in that day, if they could come. Or the next day, if they couldn't come that day. We'd prefer to see them today and deal with the problem, stabilise it. So it was very difficult, and this is after one of my postgrads had seen the patient and just did the initial bit, but still actually managing this patient. Obviously this tooth here, it's got to go. And unfortunately this one also has to go, the fracture is just too deep subtendinally to be able to restore it again. And this next one is a little bit doubtful too. We're still trying to come up with a final treatment plan for him, but you've got to stabilise it in the meantime. So we remove the broken bits and get the pulse out of those 2 teeth and stabilise them. They're not the most ideal restoration. It's a difficult thing to restore. We've got to actually get something in there to stabilise things and control the pain for the patient. And now at least he can eat and he can clean his teeth, which he couldn't do before. And that buys us a little bit of time to then decide what we're going to do with his teeth. So the basic part of emergency management, you have to think about those things. It's really quite simple. Obviously, you've got to do a thorough examination and diagnose so you know all the injuries that are there, and that will determine what you're going to do with your treatment. But it really doesn't matter detail of the injuries so much. You've got to think simply. So if tissues are not where they should be, you've got to reposition them. So if the tooth's extruded, push it back in place. If it's had holes, put it back in. If there's a bone fracture, which there often will be when you've had displacement of the tooth, you've got to get the bone back in place. That's usually pretty simple. Once you've got, so lateral luxation, you reposition the tooth. The broken bone's attached to the tooth, so you're pretty much back in place once you reposition the tooth. And the soft tissues, lacerations, suture, don't leave them in this sort of displaced position, because then you'll get scar tissue and fibrous healing that never going to look right, and all sorts of problems. So you don't get the teeth in place, you don't get the bone in place, you don't get the right sort of healing of those tissues. So get the tissues back in place and stabilise them. And that means things like a splint, and splints are not that difficult to do. A bit of wire, a bit of composite, or maybe fishing wire and composite if you want a flexible splint. Pretty simple. Sutures, the whole soft tissues back in place. And then temporary restorations if you had fractures of teeth. Some cases might need pulse removed, as we've just talked about. So your emergency management might need a little bit more than just those first couple of steps. Obviously, you need to provide advice and talk to the patient about what's going on and what might eventuate from here on, and deal with any pain that they might have. But the really surprising thing for a lot of people, especially patients, is that once you do this repositioning and stabilisation, they don't have pain. I remember one particular patient, I was treating the mother of this patient just for routine root canal work, and on a Saturday afternoon I got a phone call from her son, who was about 14 or 15 at the time, playing football, and he got kicked in the face and broken several teeth and lateral luxation one, complicated crown root fracture on another one, crown fracture on another. I can't remember all the details of it. I went in on a Saturday afternoon and we managed to get him back in shape. My mother sitting in the corner, sort of, looking occasionally, really worried about her son who's had his face all smashed up. And after, it took me a couple of hours because I was in there by myself. I didn't have an assistant with me, and she was no good because she was panicking about her son. Put everything back in place and talked to her about what to do and everything else. And about 8 o'clock that night, I got a phone call from her. What's happened? She just wanted to ring and tell her she couldn't believe it, but he had a normal meal that night. I said, well, actually, that's good, and I'm not surprised because once you stabilise things, there shouldn't be any pain. It's just like a broken arm. Once the plaster goes on and it picks them up flat on the ground, it doesn't hurt. You see people walk around with a cast on their arm as though nothing has happened. So as long as everything is back in place, there's no pain. And the other important thing to do is to arrange your follow-up. Really, really important. That's, and the follow-up is when you then decide what else you might have to do, depending on what findings you get with your tests and radiographs and things over time. So emergency management, it can be stressful, yes. It can be a bit to do, but the concept of it is actually very, very simple. And if you just think along those lines, then it shouldn't be too hard to work out what to do for all the different injuries. This was another thing, the sooner you manage these cases, the better. There's nothing worse than a patient who comes in 2 or 3 days afterwards. They've had something hit them in the teeth, which usually means the teeth get hit as well. So then you've got swelling. And someone with a swollen face is difficult to treat. So if you can see them early, much, much better. Same with those cases where you need to start the root canal treatment as soon as possible. Do it on the top at the time of the emergency treatment. Don't say come back in a couple of days. You're just making it hard for yourself and for the patient. So much easier when there's no swelling. This was another case where a patient was seen by a dentist a couple of hours after trauma, but didn't do anything. Also met another dentist who then referred to us, but, well, I say didn't do anything. Actually, he did. He wrote some amoxicillin through it. Good old amoxicillin again. Imagine for trauma, apparently. Don't need antibiotics for these things. And then got a referral from the second dentist. And you can see there's root fracture and displacement of that fractured portion. There's extrusion of this tooth here. There's probably a lateral luxation of that one. There's a lot of teeth that are not in their normal position. You shouldn't leave a patient like that and just give them antibiotics. This is after seeing one of the endodontists at the school where the emergency treatment was done. You can see, again, the swollen lip makes the treatment so much more difficult. Basically, you've got to reposition things. That's what's been done here, and then a Smith's been in place. In that case, that leads me on to the third thing I wanted to mention, that's managing root fractures, because there was a root fracture in that case. I see here, around about mid-root. Root fractures is something that has, I don't know why, but many people seem to want to take pulse out of teeth that have had root fractures. It's the worst thing you can do for a root fracture. Okay? So what you've got to, root fracture, you've got to think about what's happened here. Most root fractured teeth have a very good prognosis. The ones that have a fracture out of bone, so supracrestal fractures, they're a little bit different. But if the fracture is within bone, the root that is within bone, then they have a good prognosis. It will depend on a few factors. One is whether or not the coronal fragment is displaced as part of the injury, and then what type of displacement and how extensive it is, and then the level of the fracture. So traditionally we have talked about root fractures as being apical third, middle third, coronal third. Just a couple of years ago I proposed that we should actually change that classification, and that has now happened in Andreas's textbook, only because I wrote the chapter. So we put the case that fractures in a coronal third of the tooth is actually a fair bit of the tooth root. The prognosis is actually quite different if it's a fracture out of bone compared to a fracture in bone. So that's why we came up with this subgrouping of coronal third fractures. So that the apical third, middle third, and coronal third in bone all have a good prognosis. It's the last one that's the problem. And the more apical the fracture is, the better the prognosis. So with these cases here, we've got a supracrestal, subcrestal, both coronal third, mid third, and apical third. This one has the best prognosis. But the other two don't want us to quite good. So thinking about, as I said, with root fractures, we've also got to think about what's happened to the coronal fragment. That might have concussion, it might have subluxation where it's a bit loose, it might have extrusion, coming out a little bit, it might be backward luxated, it might be avulsed. It comes out completely. So these injuries will complicate the management of a root fracture. So you effectively have to treat that coronal fragment as though it's the tooth itself and manage those injuries the same way you would if it was the entire tooth. So again, the emergency management of the root fracture, apart from the supracrestal ones, is very simple. Reposition, stabilise it, and here you want to use a rigid splint, because it is a fracture. So rigid splints we use for root fractures and bone fractures. Flexible splints we use for everything else. So rigid splint would be with wire and composite. Flexible splint with fishing wire and composite. They're the simplest ways to do it. So emergency treatment, reposition the coronal fragment if it's been displaced, put a splint on, hold the bits together, and review. Supracrestal coronal third fractures, though, you've got to look at them differently because they're not going to recover. Okay, the fracture's out of bone, you're not going to get healing. Very well. You're going to have to hold that fracture in place. So in those cases, we would remove the coronal fracture, do root canal treatment, and then restore the tooth. The tooth is going to get close to the core and crown. But you might need to do crown lengthening, you might need to do orthodontic extruding before you do crown lengthening, before you do the crown. So they're a lot more complicated. And obviously you're not going to do all that as part of your emergency treatment. But you might need to remove the coronal fragment, get your root canal treatment started to stabilise the tooth and get the patient out of pain. So all the others, though, as I say, just reposition, stabilise, and review. And the reason for doing that is to get recovery of the pulp. The ideal healing response following a root fracture is to get healing with calcified tissue. What we mean by that is, like this diagram suggests, that we get some healing with dentin along the walls of the canal. So the pulp becomes a little bit narrow, and typically over time the whole pulp calcifies to varying extents. But what we want is to get healing across there. We might also get some healing with cementum on the outside of the tooth. The only way that can happen is if the fragments are put back together and held in place. So we recommend you split those, the rigid splint, and for 3 months. So that's about the time it takes for that hard tissue to repair. And here are 2 different cases. One's 18 months after the trauma, coronal third fracture that's in bone. Another one here, only a couple of millimetres in bone. 25 years later, it's still okay. Other types of healing can occur, and the healing with connective tissue is okay. That basically, you might get some very ligament effectively into the fracture line a little bit, but you don't get hard tissue. Or you might get connective tissue and bone. That typically occurs in young patients because of their abdominal downgrowth as they develop. So the coronal fragment comes down with the bone and the apical fragment stays where it was. The fourth type of response is the one we don't want, and that's the granulation tissue forming in the fracture line. And that's because of pulp necrosis and infection of the coronal fragment root canal system. And that doesn't happen immediately. This will take usually about 3 to 4 months before it's obvious that it's happening. So again, with all fractures apart from the superficial ones, reposition, splint, review. Don't start root canal treatment as part of your emergency, except for these cases here. If the coronal fragment does develop pulp necrosis and infection of the root canal system, then we just treat it to the fracture line. It's only about a quarter of cases that have this. Now, they don't all happen within 3 or 4 months, because sometimes it's years later. So if the pulp is okay by 3 to 4 months, pretty good chance it's going to be okay for a long time, maybe even for the rest of that patient's life. So, yeah, 1 in 4, you might have to do something about it. So it's either 3 or 4 months after trauma or many years later. In that case, just treat it to the fracture line. Not like this dentist who started his treatment and part of it was an inadequate temporary restoration, but he got all the way to the apex, and now we have periodontitis. Should have just gone to the fracture line. Because the pulp in the apical fragment stays normal. Because nothing has happened to the neurovascular supply coming into the apex. The injury has occurred here. Case I saw a few years back where it wasn't the most ideal splint, but it was already on by the time I saw the patient. The dentist was a bit composite. It held the tooth, the fragments in place, so I wasn't going to traumatise the tooth by taking it off just to replace it. That's not what I would ideally do. I'd rather see it with one composite. But you can see here, a week later, he was actually complaining of the tooth being sensitive to hot things and cold things. That's okay, because he had reversible pulpitis as a result of the trauma. Now, I wasn't going to go and take the pulp out because of that. Just give it a little bit of time to recover. And normally what I do here, and I haven't shown every radiograph, but I would see the patient monthly for the first 3 months. So the radiograph and pulp test. And with this guy, by the time I saw him, so it was 1 week after the trauma, and then about 3 weeks later, his pulpitis had resolved. And you can see here the pulp test was quite normal. 5 years, it wasn't responding to CO2, but that's because the canal was calcified. Look at the level of the fracture. Now, if you saw that patient clinically, and you didn't have those radiographs, you wouldn't know you had a fracture. Mobility is normal, everything's normal. So only when you take a radiograph, you see that there's been damage to that tooth in the past, but it's recovered. That's fine. Another one. This is just after trauma, a few hours later. Now, this is an interesting case because this guy went to a dentist and there's also a crown fracture at the second. So you need a cone beam. You've got to take a cone beam to see how extensive all these injuries are. You don't need a cone beam to diagnose trauma. Okay. Radiographs of the fluid. The dentist wanted to then extract those 2 teeth, put 2 implants in immediately. Fortunately, this guy was a bit smarter than the dentist. So I'll think about it. Next day he went to his general dentist who restored the 1 with the composite. And he wasn't sure what to do with the 1-2, so he sent it to a periodontist who was still thinking about implants. The periodontist rang there and said, I remember you talking about root fractures once, saying that they can recover. And I said, yeah. So I've been seeing a patient for a while now, and all I've been doing is monitor these teeth. And see when I saw him, pulp testing was normal. 1 month, months, 7 months, 11 months, they're still normal. Right? You know, somebody wanted to take those teeth out. No logical reason to do that, except not understanding what can happen to teeth following trauma. They can recover. You've got to give them a chance to recover. So with managing root fractures, to say, keep it simple. Don't do too much unless it's a super crystal fracture. And just to show you a few examples, these are all different cases. This one's 5 years later, this is 6 years later, 12 years, 2 of them, 15 years, you see some bone in there, 25, 40, 45, 50 years. Okay, one of them had root canal treatment done. The rest, nothing. So, you know, doing nothing, and actually not doing nothing, what you should be doing is monitoring and reviewing up until you're happy that things have recovered. And the ideal recommendation for the trauma, if there's nothing that actually needs active treatment, then say the root fracture, so I will see them monthly for the first 3 months while the splint is on. After that, I will see them 3 months later, another 3 months, and after 9 months, 3 months, 12 months. Remember, pulp necrosis is going to occur. It typically occurs in the first 3 or 4 months. Get to 6 months, chances are much less. Get to 9 months, 12 months, even less. After 12 months, I see them annually for 5 years. Assuming they keep coming back. I see some do, some don't. For 5 years, I say, I'll see them in 3 or 4 years' time. I'll keep following up for as long as I can. As long as I'll keep coming back to see me. That's how we should manage trauma. But unfortunately, sometimes people jump in too quick to do things that weren't necessary. So they're the 3 problem areas that I see, and at times it's frustrating when things are not done or things are done that shouldn't be done. So be a little bit conservative when you need to be, but also don't be afraid to do things when you should do them. It's just a matter of knowing the distinction between when to and when not to treat. So thank you very much again for the invitation to speak. And
Paul's been really gracious enough to allow us to video tonight's lecture, so let your peers know, and also can then provide anything we can bring Cheryl, and she'll tell you the YouTube thing. And so the lecturers who give us talks are usually our go-to specialists, and tonight Paul's been our go-to endodontist for many years, and remember he runs a business as well, and earlier on there was a link there, or there was an email address, and he is phenomenal in terms of you have an inquiry and he'll get back to you within usually an hour or within a couple of hours, and it's unbelievable in terms of the feedback you get to be able to give to your patients, and it's not a matter of sending a referral and an office and so on. So he's our go-to specialist. He runs a business. He appreciates your business, and yes, I am his PR man, but at the end of the day, he won't bag you either, because there are some people who sort of roll their eyes and so on. But he's here to help us. So tonight, thanks very much for giving us the lecture.
Thank you. I'm happy to take questions if people want, but you have to go at a time.